Pharmacy Times. Everything pharmacy, every day.
The recent HHS policy changes really fundamentally reorganize the childhood immunization schedule kind of into three categories now. First, vaccines that remain universally recommended for all children. This is what we've done for decades. Second, though, is vaccines recommended for certain high-risk groups or populations. And third, and probably most consequentially here, is vaccines that have been moved into a category that we're familiar with called shared clinical decision making. This is where vaccination is no longer the routine default, but instead depends on an individualized discussion between providers and families. Under this new policy, several vaccines that have long been considered foundational to childhood protection have been removed from the universal recommendation. This includes moving elements of, for example, hepatitis B, influenza, Hep A, meningococcal vaccination into either shared clinical decision-making or high-risk categories. In addition, the HPV vaccination has been substantially changed. Under the new HHS guidance, HPV vaccination has been reduced from a 2-dose to a single dose, despite the American Academy of Pediatrics continuing to recommend the established 2-dose series for optimal cancer prevention. And these changes were made without a recommendation from the CDC's Advisory Committee on Immunization Practices, or the ACIP, and without endorsement from any major medical or pharmacy organization, such as the American Academy of Pediatrics or the American Pharmacists Association. HHS has suggested that these changes move the U.S. closer to the childhood immunization schedules of countries like Denmark, but that comparison really does not hold up well. Denmark and the United States, if you haven't thought about it, are fundamentally different in healthcare infrastructure, population size and diversity, access to care, and disease epidemiology. Denmark, for example, has universal healthcare coverage, integrated medical records, and highly reliable follow-up. The US, on the other hand, has a healthcare system that's fragmented and uneven, and making clear universal recommendations especially important to prevent children from falling through gaps in care. Importantly, according to CDC guidance, shared clinical decision-making was originally intended for situations where individuals may benefit from vaccination, but broad vaccination of that group is unlikely to have population-level impact, not for routine childhood vaccines that have historically driven widespread disease prevention. This shift represents a move away from population-level prevention toward individualized risk assessment, and that has serious implications in the U.S. context. It's important to emphasize that HHS has stated there will be no changes in insurance coverage for vaccines moved into shared clinical decision-making or high-risk categories. Vaccines covered under Medicaid, CHIP, VFC, for example, and private insurance are expected to remain covered. However, the changed HPV vaccination is different and potentially more concerning. By reducing HPV vaccination to a single dose under HHS guidance, while AAP continues to recommend a 2-dose series, there's a real possibility that insurance coverage for the second HPV dose could be jeopardized, even though the second dose remains part of evidence-based cancer prevention. And really, beyond insurance, when vaccines move from routine to shared decision-making, many families interpret that shift as uncertainty or reduced importance. Even modest declines in uptake can lead to a resurgence of vaccine-preventable diseases, particularly those that are highly transmissible, such as measles. Last year, there were over 2,000 cases of measles, and outbreaks continue to this date in several states. This is driven by low vaccination rates for MMR. I think one of the biggest challenges pharmacists will face is helping parents understand that policy changes do not mean the science has changed. When vaccines move from routine recommendation to shared clinical decision-making, the entire practice environment shifts. Pharmacies lose the ability to use population-based tools like age prompts, routine reminders, and clear messaging. That makes vaccination accessible and equitable. Even if coverage remains, the operational barriers created by shared decision-making reduce outreach. They hamper clear advertising that we know works within stores and ultimately leads to lower vaccination rates. But it is an important reminder, though, that pharmacists are specifically identified by the CDC as healthcare providers who can perform shared clinical decision-making for vaccines. That has not changed. In practical terms, however, shared clinical decision-making makes it significantly more challenging for pharmacies to determine who should be vaccinated. Community pharmacies often lack access to complete medical histories, prenatal records, or household exposure data. Yet shared clinical decision-making assumes an individualized risk assessment. As a result, pharmacists must rely on patients to self-identify risk, which we all know doesn't always work very well. Shared clinical decision-making also changes how pharmacists are allowed to communicate. Routine vaccines can be prompted confidently as standard preventative care. Under shared clinical decision-making, messaging becomes qualified and cautious. Things like may be appropriate for some individuals, which reduces the urgency, increases confusion, and again, leads to lower vaccine uptake. And of course, there are also workflow implications. Shared clinical decision-making places greater documentation and counseling responsibility on pharmacists, which in a busy community setting can discourage proactive recommendations and shift vaccination to a patient-initiated model. The net effect is that families who benefit most from pharmacy access, for example, those with limited primary care, language barriers, or time constraints, are the ones most likely to not get vaccinated. Well, consistent messaging from healthcare professionals is essential. That goes without saying, especially during periods of uncertainty, like we're going through right now. When pediatricians, family physicians, pharmacists, and public health leaders deliver aligned messages, it reinforces trust. When messages conflict, uncertainty grows, and uncertainty is where misinformation thrives. Recently, the National Foundation for Infectious Diseases, along with more than 70 of the leading medical and public health organizations, signed on to an NFID letter to HHS calling for U.S. childhood immunization recommendations to remain grounded in transparent, evidence-based review and scientific consensus, warning that unilateral changes risk confusion and harm to children. Clear, consistent communication across healthcare professionals is critical to maintaining public confidence in vaccines. Well, that's exactly it. In this environment, pharmacists have an especially important role to play. For childhood and adolescent immunizations, pharmacists should anchor counseling and practice to evidence-based guidance from the American Academy of Pediatrics and the American Academy of Family Physicians, which continue to recommend the routine childhood immunization schedule developed through rigorous scientific consensus. This includes continuing support for the two-dose HPV vaccination series, which remains the standard recommended by pediatric and family medicine experts for effective cancer prevention. In community pharmacy settings, pharmacists can reinforce messages by AAP and AAFP that vaccines remain covered, evidence-based, and strongly supported by clinical experts, even when federal policy has gone astray. By doing so, pharmacists can help ensure that policy shifts do not translate into missed doses, incomplete series, and of course, more preventable disease. Sure. I want to emphasize just how impactful routine vaccination for children has been in the United States. According to a recent CDC analysis of children who were born between 1994 to 2023, routine childhood immunizations are estimated to have prevented approximately 508 million cases of illness. That's about 32 million hospitalizations and over 1.1 million deaths. That is millions of lives and countless hospital stays avoided. From an economic perspective, those public health gains translate into enormous benefits. Also from the same study, from the CDC again, an estimated 540 billion in direct savings from avoided medical care and nearly 2.7 trillion with a T in societal savings when you account for productivity, work time saved, and broader economic impact. This underscores why routine, high vaccine coverage matters, not just for individual children, but for families, communities, and the nation as a whole. It's one of the most powerful and public health interventions that we have.